Opioid Theory, Part 1 of 2. Hi, I'm Jonathan, a palliative care physician. The purpose of this video is to give you opioid facts to help with your term. The opioid practice videos will give you examples to put these facts into practice. In reality, please discuss any cases of opioid conversion or toxicity with the palliative care team and/or your specialist rather than managing it on your own. Dosing of opioids can be a bit like cooking. Firstly, it's a combination of guidelines or knowledge, but also subjective feel. Secondly, just as ways to cook the same dish varies widely, so do ways to use opioids for pain relief, and you will see significant variation amongst different doctors. These are neither right nor wrong, just different schools of cooking or prescribing. Sometimes you need to break your own rules if things are working for the patient. Finally, just as in cooking where one keeps tasting the food to know how to adjust the recipe, it's so important to keep talking to the patient and carer about efficacy and even any subtle side effects so that you know how to adjust the opioids. This slide summarizes the most common opioid choices. I would advise taking a photo of this slide and the next to keep on your phone as a reference. The second column shows the ratio of the different opioids in comparison to oral morphine. The third and fourth columns provide some common brand names of short and long-acting formulations. The final two columns talk about use in renal or liver failure. Of note, I want to mention Targan is not recommended in liver failure or severe renal failure. Targan contains slow-release oxycodone and naloxone. The naloxone is meant to be fully metabolized first pass by the liver, so that it only has its effect in the gut to reduce constipation. In liver failure, where that first pass effect is not effective, but also in severe renal failure where the naloxone can accumulate, that naloxone can escape systemically and start antagonizing the opioid at the pain receptor level. Because in palliative care patients there is a significant chance that liver or renal failure will develop over time, we try to avoid Targan where possible. Specifically, I also want to point out that methadone, which has a big role to play in palliative care, should only be used or titrated by the palliative care team due to its complex pharmacokinetics. This slide shows ratios of a fentanyl patch to oral morphine. For instance, a 12 microgram per hour fentanyl patch, which is usually replaced every 3 days, delivers rough equivalent of regular 5 milligrams oral morphine every 4 hours. That's a reasonable dose, hence even the lowest fentanyl patch is usually not appropriate for opioid-naive patients. In our LHD, by far the most commonly used subcutaneous opioids are morphine and hydromorphone. For both these drugs, when converting from oral to subcutaneous, we divide the dose by 2, and when converting back, we multiply by 2. For instance, 2 milligrams of oral morphine is equivalent to 1 milligram of subcutaneous morphine. Note, for BPTs sitting FRACP exams, I believe the ratio used in your exam is 1 to 3, not 1 to 2. The opioid conversion ratios described thus far are the ones used by our LHD. Every LHD has their own ratios which you will need to follow if you move network. If you ever work somewhere without established ratios, the Faculty of Pain Medicine Australia and New Zealand College of Anaesthetists also has a document of suggested ratios that is available free on the internet and is also cited by the therapeutic guidelines. The ratios are almost the same as our LHDs, but small differences exist, most notably using a 3-to-1 conversion from oral to subcut morphine when we would use 2-to-1. Again, I suspect the FRACP exam bases its ratios on this table. Reasons why opioid switching occurs include needing to change route, as each opioid is not always available in every single route, new renal or liver failure, adverse reactions to one particular opioid, lack of effect of initial opioid, or to start a long or short-acting opioid. Let's talk about onset, peak, and duration of action, starting from the shortest to longest acting. Fentanyl is the only opioid with ultra-short-acting sublingual formulations, branch names being Abstral, Actic, or Fentora. These have onset of action 10 to 20 minutes, peak effect 30 to 60 minutes, and duration of action approximately 1 to 2 hours. These are useful for pain on movement, the name for which is incident pain. For instance, it is a good option for a patient with pain when weight-bearing to use prior to showering or physiotherapy. They can take these medications 10 to 15 minutes before that planned activity, and the active effect on the body will hopefully wear off after 1 to 2 hours. Short-acting oral formulations, for instance Ordine, Endone, oral dilaudid, have onset of action 15 to 30 minutes, peak effect approximately 1 hour, and duration of action approximately 4 hours, though likely range 3 to 6 hours. For this reason, when charted regularly in someone with normal liver and renal function, the default should be to chart Q4 hourly. Short-acting subcutaneous formulations, for instance subcutaneous morphine or subcutaneous hydromorphone or dilaudid, have onset of action 10 to 20 minutes, peak effect approximately 30 to 60 minutes, and duration of action approximately 4 hours. When charted regularly in someone with normal liver and renal function, the default should also be to chart Q4 hourly. 12-hour formulations, for instance MS-Contin or OxyContin, have maximal plasma concentrations 3 to 5 hours post-dose and duration of action approximately 12 hours. For obvious reasons, when charted regularly, the default should be to chart BD. 24-hour formulations such as Jonista or Kapanol have a broad relative plateau plasma concentration by 5 to 8 hours post-dose and duration of action approximately 24 hours. When charted regularly, the default should be to chart daily, although Kapanol can also be charted BD. Fentanyl patches slowly release medication into the skin and form a reservoir, which then slowly releases medication into the bloodstream. Serum concentrations increase gradually, with a minimal effect by 6 hours, reasonable dose level by 12 to 24 hours, and duration of action for approximately 3 days. The default should be to chart every 3 days. Hydromorphone is a very important drug because of its preferred use in renal failure. Milligram for milligram, it is 5 times stronger than morphine. Errors during opioid switching to and from hydromorphone has led to very serious and yes, even fatal patient outcomes in the past. Please familiarize yourself with the clinical business rule on the intranet, which often gets updated on the latest rules about its prescribing. The following are some rules as of the time of making this video in 2021. Always initiate it with involvement of a specialist. See the clinical business rule for more details of which specialists are allowed to initiate it. Document whom it has been discussed with in the order comments and a progress note. All hydromorphone orders must also be checked by another doctor, a pharmacist, or a nurse practitioner specializing in palliative care, renal supportive care, or pain medicine. Where 2 doctors are prescribing and checking, at least one must be a registrar or above. Document the name and role of the person checking the order in the order comments and a progress note. An example of documentation in the medication order comments and a progress note is demonstrated here. Please document it as hydromorphone in brackets dilaudid. Note how we capitalize hydro and include the brand name dilaudid in brackets so it doesn't get confused with morphine. It is also particularly important to document calculations during any switching. Opioid Theory Part 2 video will provide some more rules about opioid switching and discuss side effects and toxicity. Here are some key references.